Good evening, ladies and gentlemen. Welcome back to DentLinks. My name is Peter Tawil, and it's my pleasure to present to you tonight Dr. Claire El Hashim Kaloustian. She's a pediatric dentist and a specialist in pediatric dentistry, and also a lecturer and a teacher, assistant professor at St. Joseph University. It is my pleasure to introduce you today to the topic of conservative treatment versus extraction of primary teeth and how to take the right decision. Without further ado, please, Dr. Claire, the floor is all yours. Okay.
Thank you, Peter, for this kind introduction and for having me. I am proud to give the first seminar about pediatric dentistry in DentLinks about a very important topic, also a controversial topic, which is the extraction versus the restoration of primary teeth. We will try to see during this short presentation on which criteria we can base this decision, keeping in mind that we know today that the anatomy of primary teeth, as you can see on this reconstructed micro-CT that we did, is very complex. Contrary to adults, when we work with the young children, it's not only technical. There's also a psychological side, which is as important as the technical side. Extraction, whatever we do, no matter how much we prepare the child, is seen as a traumatizing and violent act. Moreover, it is well known that children experience pain differently than adults. They have physiological parameters that are altered very quickly when they are stressed, like their heart rate and the cortisol level. But also, and most importantly, they can remember painful experiences from very early in their life. This was actually discussed in our upcoming article about different local anesthesia injection systems in children. I'm sure you all have patients that still carry on their fear from when they were very young. Imagine being a child, age 6 or 7, having this kind of appliance on the upper arch for 5 to 6 years, or this kind of appliance on the lower arch. I think we can all agree that nobody wants this, especially that these appliances accumulate plaque, they are very hard to clean, and they often break. Children are first excited to have an appliance in their mouth, but after a few months, they start asking for how long they need to keep it. So our first option, no matter the difficulty of the treatment that can be related, for example, to the anatomy, our first option is always a conservative treatment. It doesn't mean that we never have to extract, like in this case, for example, where there is a complete root resorption, or when you have a very large radiolucity that is close to the germ, and a patient that we can't follow up. So in this case, our only option is here we placed an lingual arch and then we extract it. This is easy to decide when we are working with molars because we don't have another criteria to consider, and which is aesthetics in children. Children today are bullied because of their teeth, and parents are very concerned, and they would rather avoid extraction whenever possible. So the question really is, in a case like this one, a young patient, should we extract all the decayed teeth or do some endo and zirconia crowns? Or even in a case like this one, we did the pulpotomies with MTA. We placed 2 fiber posts on the laterals. Of course, we didn't insert the fiber post in the root entirely. We just put 1-2 millimeters just to gain some retention for the build-up. And we covered all the teeth with zirconia crown. And this is an interesting case of a very young boy who was 3 at the time. And after several attempts at the chair, we decided to go for general anesthesia. And during GA, we had 2 options. Extract and traumatize the patient and his family, because in this case, I don't know if you can see clearly, the second molars are not fully erupt yet. So we can't even do an appliance. Or what we did, we opted for pulpotomy and then very aesthetic zirconia crowns. Even in cases like this one, where we have perio-endo involvement, sinus tract, or even swelling, we should go for pulp therapy. Keeping in mind that extraction is always possible if this treatment fails. But anyway, we will try to do our best to make it work. We need to have some standards. In pulpotomy, a good recent pre-op, a thorough caries control, and bleeding control. After access opening, we need to make sure that we have what we call light bleeding. This means we don't have necrosis, partial or total necrosis, but also we don't have inflammation, excess bleeding. And of course, the usage of biocompatible materials. Here I'm using the MTA, but you can use any other material like biodentin or even now bioceramics. I'm using the MAP1 system here to inject the MTA slowly to make sure there are no voids. And after checking for the MTA seal, we do the coronal restoration, which is here a stainless steel crown. What about pulpectomy? For pulpotomy, there's a consensus. While pulpectomy is very controversial, and a lot of dentists, even specialists, avoid it. In my opinion, and by referring to the literature, pulpotomy, which was actually described in the 70s, if done properly, can have very high success rate. Done properly means, of course, we have to start with perfect isolation, so liquid dam, rubber dam, and also complete elimination of the caries. And an important step is the elimination of the infected dentine completely before accessing the pulp chamber. And this is very important. We don't want to contaminate our endodontic system. This can endanger the treatment. At some point, we'll have pulp exposure, and here it is important to switch to a safety burr like EndoZ or equivalent. And under microscope, we can see here we have 4 canals. These are the distal canals, and here are the mesial canals. I finished my access cavity using ultrasounds, and I take my working lens using an apex locator. Yes, it is recommended to use apex locator, and this is supported in the literature, on primary teeth to gain time, but also it is accurate. And of course, we use the mechanical preparation. This is published since 2002. Here I'm using the TS1 instrument from the 2-shape system, which is a 4% instrument. Of course, a thorough irrigation protocol, and I'm also using the TS2 instrument from the same system, which is a 6% instrument. I use this instrument in all 4 canals until the working lens that was given by the apex locator. I use it with a light brushing motion. I just want to reach my working lens and then I retrieve. Also, we need to activate the irrigant that we are using. We can use any passive ultrasonic irrigation device or sonic irrigation. And we will move on to the final phase, which is the obturation that starts with the drying. Here I'm using a micro cannula. You can see how the 4 canals are prepared and dry. And we will also dry with the sterile paper points. The final phase will be the obturation. For the obturation, we are using here a squirting technique, which is basically a mix of calcium hydroxide and iodoform that is injected directly in the canals. And here is how the access cavity will look like. Afterwards, we'll move on to the reconstruction of the coronal part. And this is very also important to be done using the rubber dam. You can use any core material you want. Here I'm using the SDR because I think it's very easy to apply and very quick also. After checking for the coronal seal, we will move on to do a stainless steel crown. All this to tell you that we shouldn't rely on rumors, legends, and apprehension. In the literature, there are articles stating a success rate that goes as high as 97%. And here I only put 2 articles, but there are a lot of publications now about pulpectomy and the success rate. We should base our treatment only on this evidence-based dentistry. This will allow us to free ourselves from this contradictory love-hate relationship with this endo-pedo act and free ourselves from the legendary frustration. But of course, this is easier said than done. When a lot of dentists and even specialists still think that pulpectomy is useless and it doesn't work, then we should ask ourselves what is wrong, what's not working. And what is not working is the anatomy of primary teeth, which is still unknown. If we look in the literature, there are very few articles that describe the anatomy of primary teeth using different techniques like clearing techniques, microscope, or even imagery techniques like CBCT and the micro-CT recently. What we know from these techniques is mostly descriptive. We know, for example, the canal form. We know that we have a lot of lateral canals, isthmus and anastomosis, and we know that the dentine is thin. Are these criteria enough to determine the complexity of this root canal system? As you can see on this extracted molar that we scanned and reconstructed, the system is very complex. And this is why we decided to do an anatomical study about the root canal anatomy of primary teeth, and we started with the mandibular molars. We used the micro-CT to do the study, and here are the specifications that we used for the scans. The objective was to transform simple DICOM data into quantifiable 3D images. The methodology we used is unpublished, and it was designed specifically for this study. We started by reorienting all the teeth using 3 planes. First, an axial plane that is parallel to the occlusal plane, then a second plane that is perpendicular to the first plane and that passes through the middle of the mesial and distal surfaces at the level of the pulp chamber, and a third buccolingual plane that is perpendicular to both previous planes. So all teeth were reoriented using the 3 planes to have reproducible measurements. Then for each canal, we traced a custom curve that started 1 millimeter above the furcation to the apex. Through this curve, we were able to determine the length of the canals, but also we obtained sections that are perpendicular to this curve. 3 important sections, a coronal section that starts 1 millimeter below the canal orifice, an apical section that is 1 millimeter above the apex, and the middle section between them. Here is an example of the 3 sections that were reconstructed for our calculations at 3 levels. First, we started by tracing the circle that allowed us to determine the center of the canal. Then we measured the dentine thickness around the canal, but also we measured an important data, which is the minimal dentine thickness and its direction. And we also measured the diameter mesio-distally and buccolingually. The highlight of this study was first the models that we were able to obtain from sad black and white images to artistic models. Then, and this is interesting, the methodology we used for the measurements that gave us accurate results with fixed landmarks, and it would be interesting to replicate this methodology on all primary teeth, especially in regard to the dentine thickness and the minimal dentine thickness. If you can see here in green, what I circled is the minimal dentine thickness at this cross section, and this is important. Why? If we take the example of the two-shape system, which I used earlier, the TS1 instrument at 12 millimeter, which is where the previous cross-section was done, has a diameter of 0.73 millimeter, which is less than 0.9. While the second instrument, which is the TS2, at the same level, has a diameter of 0.97, which is higher than 0.9. So it isn't always possible to use safely these instruments. And even though these instruments are heat treated, and they or any other mechanical night-eye available instrument now, they were not perceived to the usage on primary teeth, because the dentine thickness on primary teeth and the length of the canals is very different from permanent teeth. So it is not recommended to use them on primary teeth, and especially when we know that there are lateral canals everywhere in the root, not only in the middle part, but also in the apical and also in the coronal level. And we were able to determine also the continuous presence of the isthmus. And we know that these regions are not accessible by the instrument. So I think it would be interesting to create a whole new instrumentation for the usage on primary teeth, and also methods of activation. All this keeping in mind that this treatment should be quick, efficient, and safe for the child. If you want to know more about this study and view the results in details, it was published in the European Archives of Pediatric Dentistry, and it allowed us to have an exhaustive anatomical data, which I think renders the treatment reproducible. And this is very, very important to any medical procedure. So when we do this kind of treatment, we will have functionality, but also with like everything in dentistry, with functionality comes an artistic touch. I hope that you like this presentation, and I hope that this presentation will allow general dentists to see that we do have options to treat primary teeth, and it will introduce them to modern pediatric dentistry, where we use a lot of new materials and new technologies. Thank you very much.